With a Discseel procedure, the question that many people ask is, okay, well, what happens to the disc herniation? How does that solve the problem? We just don't understand the pathology as it relates to that leaky disc phenomena that's basically causing irritation. It's not so much the actual disc herniation itself and the compression from that. It's really the leaky disc phenomena that's creating the irritation. Most people have the impression that the actual herniated material is pressing against the nerve root. And that's why we get sciatica, that's why we get the leg pain, that's why we get the arm pain, or the radiculopathy is what we would call that. And in very rare cases, the disc herniation does compress the nerve root, but it is in very rare cases. The vast majority of individuals who have leg pain or arm pain related to a disc herniation, it's not due to true compression of the nerve root in terms of a physical sense, where the actual herniated material is pressing into the nerve root and causing that symptomatology. In the majority of the cases, what's happening is that we're just getting irritation around an area that has, let's say, less space as a result of the disc herniation, and that irritation or inflammatory process is causing irritation to the nerve root, and as a result, we're getting the symptoms associated with that particular disc. Now, because of that, that is the primary reason why Discseel can be a very effective procedure. We all realize that cutting a portion of the disc out is going to improve the amount of space that the nerve occupies, and as a result, it'll become less inflamed over time, and as a result, we won't have that leg pain or arm pain by cutting things out. And that's a very mechanical thought process, and that makes complete sense. We cut that out, gives us more space, takes pressure off of the nerve root, or takes the irritant away from where the nerve root is, and as a result, we don't get that inflammatory process, and the symptomatology changes in response to that invasive procedure. And that's really the basis for surgery when we present that way, right? So either we remove a portion of the disc or we cut a portion of the bone to make space so that the irritation that takes place that does irritate the nerve root, there's more space there for it to dissipate, and as a result, we don't have that problem. Now, when it comes to Discseel, it's very different. You see, the way that it works is a disc is basically a specialized ligament. It's a very broad, very dense ring of ligamentous material. And on the inside, there's a small pocket of gelatinous material, which gives it its properties. And in order for a disc to herniate, it doesn't happen from the outside. It happens from the inside, where basically the ligament becomes torn on the inside. We call that an annular tear because that outer ring is called the annulus. And when that becomes torn, a little bit of that jelly can protrude into where the ligament is, and it looks like a herniation or a protrusion. On MRI, it kind of looks like a little nipple that's kind of sticking out. In most cases, obviously for most of the patients that we see, that disc issue is contained within the outer ring of the annulus, and it really just looks like an outpocketing on MRI when you visualize it on film. So what we do in the Discseel procedure is when we put a needle into the disc, into where the gelatinous material would occupy, and we put sealant in there, it seals the inside where the annular tear is, almost like fix-a-flat for a car. It's probably the best analogy that I have, because most people have used that in the past. So essentially it works in much the same way. We put a needle into the disc in a minimally invasive fashion. We inject dye so that we can see exactly where the annular tear is. And then when we inject fibrin into the disc, it seals it from the inside. And as a result, the irritation that occurs where that nerve root is no longer exists. So in many cases with Discseel procedures in Discseel patients is we see resolution of leg pain at a pretty quick pace because that fibrin sealant has almost an immediate effect. And again, it's back to the misnomer that it's true compression on the nerve, right? So the issue with the inner material, the gelatinous inner material, it's called the nucleus pulposus. It is highly inflammatory, and it's not designed to be outside that outer ring of the disc ligament itself. So because it never really goes from the inside to the outside, there's never any issues. But when we have these small annular tears, a portion of that material can leak through the disc. And they commonly call it leaky disc syndrome for that reason. And then as soon as small particles get to the outside of the disc, it reacts with our body in terms of the inflammatory process and how it irritates the nerve roots once that happens. So it's not like the disc just blows out and all of a sudden it creates these neurological problems. In those cases, those are the most severe of let's say, a disc herniation in terms of pathology. A disc that is sequestered is what we would call that, where the inner material is actually pushing into the outside. Those patients never have a choice as to whether or not they should have surgery. They're always surgical, and they're typically doing that in the ER, right? Because it is highly inflammatory material. With a Discseel procedure, the question that many people ask, and rightly so, they probably should ask the question because they're thinking critically, is, okay, well, what happens to the disc herniation? How does that solve the problem? It doesn't make sense. We just don't understand the pathology as it relates to that leaky disc phenomena that's basically causing irritation. It's not so much the actual disc herniation itself and the compression from that. It's really the leaky disc phenomena that's creating the irritation. So when we seal it from the inside, we no longer allow that material to leak through the annular tear in the disc and further complicate the neurological issues by irritating them over time, right? And this is also why when you have a disc herniation, it can be asymptomatic. It doesn't always have to be symptomatic. People have disc herniations, and at certain periods, all of a sudden it becomes very symptomatic, and that's usually in relation, again, to the inflammatory process, which drives symptomatology. When we're thinking in terms of what types of protocols or interventions we should be taking part in, what we also have to do is weigh the good with the bad. So with a Discseel procedure, again, it's minimally invasive. There's no downtime. There's no need for recovery. This is not a surgical procedure, and we're not removing parts from the body. So as a result, we're really maintaining the stability of that motion segment, and we're really just doing what we can to patch it from the inside to prevent it from continuing to degenerate or get worse long term, but also to prevent it from irritating the nerve and creating that neurological compromise. The biggest distinction for a Discseel procedure is really just ruling out whether that patient requires an immediate surgical process. And usually when, things have been there for quite some time and we're starting to see really significant neurological deficits, that's when we know that it's an unstable situation, and typically surgery would be the best option for those patients. So, how do we determine that? It's not just based on symptoms. I mean, obviously you want to relate symptoms to the diagnostic studies like the MRIs, but more importantly, when the patients come in office, we want to determine if they have any weakness. We want to determine if they have abnormal sensation patterns. We want to determine if they have deep tendon reflex issues that are consistent with that particular segment. And if they do, and if it's really advanced, and if there's quite a bit of damage to that particular segment, and it's consistent with the findings, the physical exam findings, then we may send that patient out for surgery, because that would be the quickest way to, recover the neurology. So at the end of the day, what we have to be cognizant of is the neurology. We don't want to allow nerves to be damaged for long enough periods of time where we may not recover the function of that particular nerve. So that's a really important thing. And that comes with not just diagnostic studies in the form of MRI, because that's not always consistent with symptomatic presentation, but also physical exam, right? And if there's generalized weakness that's consistent with that particular segment, then, we may have a conversation with that patient and say, look, you're not a candidate for this minimally invasive process. Something more radically invasive has to be done. If you have any questions about Discseel or lumbar spine disorders, please feel free to leave a comment or reach out to us directly, or you can go and look at the rest of the playlist that we put together. We answer a lot of questions in that as well.